Right, so good evening, everybody. This month we've decided to do a theme. It's been a while, the theme was at the beginning spleen and liver CT, but there's actually quite a lot on that, so I reduced it to liver and splenic lesions, so masses and nodules, etc., rather than everything about liver, biliary, etc. We didn't include all those things. So I prepared the spleen, and Marion prepared it's not muted.
I think Inma, if you can mute yourself. Perfect.
So yes, I've done the spleen, and Marion has done the liver. So there were quite a few actually. So 3 on the spleen only, and there were 3 also on spleen and liver where they did both, and a few on liver as well. So the first one on the spleen was one of the initial ones, so 2004 from the Vet Radiology and Ultrasound, looking at the comparison between malignant and non-malignant splenic masses using CT. So on that one, they used only one contrast phase, and the contrast phase, what they called immediate contrast phase.
Muss natürlich Audio anmachen, ja.
And so they had roughly 60% of non-malignant masses, nodular hyperplasia and hematoma, and 40% malignant masses, mostly hemangiosarcoma there. And so that's the initial study, and that's, I must say, one that I had quite well in my mind, probably because I studied it for my boards. And that's the one where they found really a difference between malignant and non-malignant lesions, thinking that the threshold value of 55 Hounsfield unit was quite good to differentiate them, with malignant masses being hypoattenuating compared to non-malignant masses. So you can see here on post-contrast, well, they found that there was a difference on pre and post-contrast, but on post-contrast, they wrote that the nodular hyperplasia, there were around 90 Hounsfield units, hematomas around 60, and the malignant splenic masses were attenuation around 40. And that's where then they based their statistics on that, and then that they had this threshold value to use. So I must say I still sometimes look at it and consider it, although now I usually just mention that it could be benign versus malignant in my reports. I'm still looking at that. So for this first study, yeah, they definitely mentioned that that there were a difference, and the CT attenuation for that. So that's the example they showed on their images with nodular hyperplasia, this one and this one, and hematoma, quite mixed in attenuation, and the hemangiosarcoma, which was quite necrotic or cavitated in that one, and definitely, yeah, much more hypoattenuating than the others based on this. They mentioned in the discussion that the dogs with also malignant masses had a bit more of peritoneal effusion, but and compare with the dog with non-malignant masses that had less chance of having peritoneal effusion. But again, yeah, not something clear cut. Then something interesting is that they had no differences between malignant and non-malignant for the size of the masses. So that none of them will. Sorry, that's my children. Yeah. So the size in that, they didn't have statistical difference to help them use that as a criteria. Second study. So that was much later, so 2016. So this one, they evaluated hepatic and splenic masses. So I'm just going to talk about the splenic masses. On that one, so dual phase CT, so they used pre-contrast and post-contrast with what they call an early phase and a delayed phase after 60 seconds. And on that one, they had 31 splenic masses, a bit roughly the same type of repartition, yeah, between malignant and malignant, a bit different, but yeah. So, but again, mostly hematomas, nodular hyperplasia, and a majority of hemangiosarcoma. They had a few other types of neoplasia there. In that case, however, they concluded a bit the other way around, that they that they had a lot of overlap between the findings between malignant and non-malignant splenic masses, and that they couldn't really use CT criteria to make a differentiation. So the splenic hemangiosarcoma and the nodular hyperplasia, they showed marked generalized enhancement in the early phase that persisted in delayed phase, and the splenic hematoma would show some enhancement, but probably less. And they could see also that in the hematomas and some of the hemangiosarcoma, there was some contrast accumulation compatible with active hemorrhage, which I must say, I've rarely seen, but they had quite a lot of proportion of it mentioning that. Yeah, and all the other criteria they used were really also not really statistically significant. So when you see they made a table with all the criteria, whether the margins were distinct or indistinct, you can see that you have a fair proportion of in each type, homogeneous versus heterogeneous, same, quite the same amount. The generalized enhancement or the peripheral enhancement, also even the peritoneal fusion, they didn't really have a statistical difference with that. Mineralization in the mass, well, just that one. So as you can see, for all the criteria they used, they didn't have much differences. So they illustrated that with those images. So that's the hemangiosarcoma on top, the hematoma, and then the nodular hyperplasia, where you could see some degree of enhancement in most of them, and quite strong enhancement at some levels in the arterial phase, early phase, for the hematoma and the hemangiosarcoma, and the nodular hyperplasia, also quite nice enhancement that they got there. So yeah, so for that one, their conclusion was mostly that they couldn't make the difference. That was an hematoma next to the splenic and another hematoma in the peritoneum. And then there was a third one, and this one is with triple phase CT of solid splenic masses. So 1 year later, this one, after the other one, so this one, they tried to do a quite complicated measurement and measured volumes, etc. But I'm not going to go into all that. For that one, they had 42 dogs with the splenic mass that had splenectomy. And again, a good proportion of hematoma, nodular hyperplasia, and hemangiosarcoma mostly, and they had few undifferentiated sarcomas. So this one, I thought the criteria they used were a bit weird, but basically they mentioned the enhancement between something poor enhancement, normal enhancement, and remarkable enhancement. So I think that were their 3 criteria. So I thought they meant iso, hypo, and hyperattenuating to the rest of the spleen, but I will go back to that, because what they call normal enhancement, I'm not sure I would have called that normal enhancement. But basically they found that nodular hyperplasia, they all had an homogeneous normal enhancement pattern. When you think that in the case before, the nodular hyperplasia was quite heterogeneous here. So, well, sorry, where was I? Then the hemangiosarcoma, they had two different types of contrast pattern. One was a homogeneous poor enhancement, so basically with a large cavity, and some had also heterogeneous remarkable enhancement pattern in the arterial and portal venous phase. So I will show you some example of that as well. And for the hematoma and the undifferentiated sarcoma, they had what they call an heterogeneous normal contrast enhancement. So their conclusion based on that was that CT was actually quite useful to make the differentiation, which I didn't really know how they got with that. So I will show you some examples. So that's the hematoma they show. So with some contrast enhancement, but that's what they call an heterogeneous normal enhancement, which is fair enough. I would say that's roughly what I would expect, like an enhancement of a spleen. So I guess that's what I would have said, yeah, normal enhancement. Nodular hyperplasia, so that's where I was not really completely agreeing with their classification there, because they call this homogeneous normal enhancement in the arterial phase, and I wouldn't say it's homogeneous, and I wouldn't say it's normal, because it's definitely hyper than the rest of the spleen. Same in the portal phase, and obviously, yeah, in the delayed phase, it's a bit more homogeneous and isoattenuating. So here, okay. So yeah, so that's where I was not completely in agreement with their classification of enhancement pattern, and that's the hemangiosarcoma cases they got. So I told you they had two patterns of enhancement that they could see. So either poor enhancement and homogeneous, and that would stay in all the phases. So basically, yeah, necrotic cavitated areas. And the other types they got was where obviously you have the central necrotic fluid area, but then they could see some areas where they have got quite a strong enhancement in the arterial and portal phase. And that's where they call it normal in the delayed phase. But again, I wouldn't say that's normal enhancement. Again, that's quite hyper-attenuating compared with the rest of the spleen. So I would still call that hyper-enhancing, or whatever you call it. So I think, and then there was another type, which was the undifferentiated sarcoma. So the undifferentiated sarcoma, there was quite they classified them as being normal but heterogeneous enhancements. Again, yeah, that's debatable, but I think that's why in their conclusion they had, I think, between the undifferentiated sarcoma and the hematomas, to be honest, I would have really much trouble to say what's the difference. I guess you have a larger cavity in that one, but yeah, so I don't think based on what they describe, that we could say again that CT is so useful to make the differentiation. I guess it can be useful maybe if you have this really very strong enhancement in the periphery, yeah, maybe to question a bit more hemangiosarcoma. But yeah, for the rest, I was not really thinking there was so many difference between hematoma and the differentiated sarcoma, for example. And I think the nodular hyperplasia definitely, well, we all suspect it when it's definitely more enhancing on all phases, that it would be something more benign like nodular hyperplasia, but yeah. What else did they mention? Yeah, the difference with other articles is here. They found that there was the size was playing a role, that nodular hyperplasia had definitely smaller size than hematomas and hemangiosarcoma. So yes, of course, and based on the example they show, yeah, this is definitely smaller. But if we go back to the previous article, that's nodular hyperplasia, and that was quite a large mass lesion. So again, I guess there's always exception to the rules there. They also found that the pre-contrast CT values of hemangiosarcoma was lower than the rest, than the benign ones, so hematoma, nodular hyperplasia, and splenic parenchyma. So I guess that could go back to the first study where they had this 55 Hounsfield unit as a threshold. That could be the case. But again, where did they measure? Did they measure just in the cavity, or did they measure everything? I guess that depends on that. So yeah, so that was about it for that one. Something that I noted from the discussion I thought was quite interesting is that, and they mentioned it in another article as well, is that on they mentioned that on histopathology, the cases of hematomas, they basically are secondary to nodular hyperplasia or extramedullary hematopoiesis, and it's rarely secondary to trauma in dog. And they mentioned that to explain the contrast enhancement that we see in those hematomas, because you would think if it would be a pure hematoma from a trauma, for example, so just blood and a big blood clot or whatever, you wouldn't expect to see contrast enhancement, or not centrally, but just in a periphery, for example. But when you think about it, a lot of those cases that we've seen, like this one, is quite heterogeneous. You see some enhancement in the middle. This one as well, which one? Yeah, that was the hematoma, where you could see again some contrast, quite marked enhancement in some areas. And I think the one they show here as well also had some enhancement. So I think it's quite interesting. They mentioned that in comparison to humans, where in humans, basically splenic hematomas are usually due to trauma, when in dogs, it's actually not that common. Obviously, you can have a splenic hematoma secondary to a trauma, but a lot of those cases where we find large hematomas in spleens, there's actually no history of trauma in those dogs. And that's why, because they are secondary to nodular hyperplasia or extramedullary hematopoiesis, that you see the contrast enhancement in those. And again, one of the reasons why for us it's definitely more difficult to say just based on the criteria of enhancement. So I thought that was interesting to mention. So that was the 3 articles really comparing hematomas, hemangiosarcoma, nodular hyperplasia. But then there were a few articles about other tumors. So there was one about mast cell tumors, and those last 3, I think we've done them in Journal Club already, so I will go a bit quicker on that. So one with the mast cell tumors. And for that one, basically, they, well, on a lot of dogs that were positive on dogs that were positive for metastasis in the liver or spleen aspirates, they just had, on those 5 dogs that had aspirated positive for mast cell, they had 4 that showed an abnormal splenic parenchyma with the nodular or diffuse heterogeneity, and 1 dog had a normal attenuation of the spleen, and some dogs had enlarged spleen, which, well, on CT sometimes doesn't mean much. Multifocal, so they basically mentioned multifocal splenic hypoattenuating lesions with mast cell tumors. I tried to go back and try to say if they mentioned if it was pre-contrast, post-contrast. They don't really say. Really in the results, which I found was quite odd, especially when you consider it's a vet radiology article done by radiologists, that it was not clearly mentioned. But I guess in the example they show here on an image, it was on post-contrast, at least for that one. So yeah, so that's what they call multifocal hypoattenuating areas in the spleen. And that was a dog positive for mast cell tumor. But again, nothing really completely specific there, I guess, that they could see. There was another one about lymphoma, again, with the involvement of splenic and liver. And for that one, so I think that one was a bit older article. They had 12 dogs with lymphoma, and on 7 dogs, the spleen appeared normal on CT. And they had 5 dogs with splenic nodules. So it was lymphoma diagnosed based on FNAs, so the liver, spleen, and lymph nodes. So I guess it was positive in all their sample. But so 7 dogs had a normal spleen, 5 dogs had splenic nodules, and then they mentioned that 2 dogs had a mass. So I guess some were overlapping, otherwise that wouldn't equal to 12, but 14. So I guess some of the 5 dogs that had nodules, they also had masses. And again, not really very characteristic. We had 4 hypoattenuating, 1 isoattenuating, and then a bit less, 3 hypoattenuating post-contrast. Here it was quite a bit delayed contrast compared with the criteria of the second study, and 2 isoattenuating. So again, nothing really much specific there. I guess hypoattenuating, isoattenuating, both are possible with lymphoma. But they mentioned in the conclusion, though, that the spleen was definitely normal in the majority of dogs, so that doesn't exclude lymphoma infiltration. And they recommend, like for the mast cell tumor, they recommend that if you want to do a proper staging, you need to do FNAs rather than just look at the CT aspects. And that's where they show the hypoattenuating nodules. So something quite ill-defined in both cases, both examples that they showed there. And the last one was the more recent one. I think it was splenic extramedullary hematopoiesis on CT. And here what they mentioned is mostly appearing as hypervascular nodules. They took dogs which all had a cytological diagnosis of extramedullary hematopoiesis and 3-phase CT. They had variable aspect again, but they thought that was the most frequent was multifocal nodules hypertenuating to the rest of the spleen, and that's seen in the earliest phase, arterial and portal phase. But they still mentioned that there were quite a lot of different aspects visible. So you could have multifocal nodular aspect. They had some 16% of cases where mass-like lesion, and they had some with diffuse heterogeneous parenchyma, and 9% that had a normal spleen on CT. So as you can see, quite a viable examples. Here they show with some rim enhancement. So again, nothing completely pathognomonic, obviously, but more hypervascular than the rest of the parenchyma. But like we saw with some hemangiosarcoma, you can have some hypervascular areas as well. And with nodular hyperplasia as well. But that's all example with multiple hyperenhancing small nodules. Definitely those were the ones where we would probably be a bit more confident to say nodular hyperplasia versus extramedullary hematopoiesis, but yeah, most lesions were hyperattenuating to parenchyma. So here you have the differentiation between arterial, portal, and interstitial. So you can see that in a later phase, the hyperattenuation decreases. But still, they had some cases with hypoattenuating lesion in the 3 phases. So like those ones with the rim enhancement, definitely those ones, I guess, would be the more difficult to call benign, just based on this, and definitely you would put both. So basically the conclusion is probably what we all write in our report, is that benign versus malignant, and we cannot say for sure. I guess it's always nice to have all those different examples and try to refer, and when you see a splenic mass, to have a look and try to see a bit what is what your mass looks more, what is more looking like one of those examples or not. But yeah, so like we suspected, it's really not clear cut. Even those 2 articles mentioned that they were that CT would be useful. I think the overall message is that yeah, it's still very difficult to say just based on the CT characteristic if it's benign or malignant. Any questions about spleen? No.
Okay, so I will share my screen.
Sorry about the noise of the kids in the background. It was bedtime.
Sorry, I need to share the screen. So let's see. Attends, Marcus. Ah, sorry. Just a minute. Sorry.
That's right.
Okay.
Yeah, maybe
So,
just increase your PowerPoint window.
yes,
so
up. I will do that. I just move this. And here is okay. You see the PowerPoint? Yes. Okay.
Yes.
So yeah. So me, I will just go through the less paper about like the hepatic masses and use of CT, and sometime about the ultrasound. And at the end, I will just go very quickly through like 3 papers that were talking about the localization of mass and within the liver through CT. So the first one, sorry, I need to do that. So the first one is from 2013, and the aim was to determine the utility of the triple phase CT to differentiate canine hepatic masses. So that quite a fair amount of dogs, 70. So they did the triple phase, and they were looking if the masses were hyper, hyzo, or hypo enhancing relatively to the surrounding hepatic parenchyma. And of course, all the masses went with a histopath examination. There were 47 hepatocellular carcinoma, 14 nodular hyperplasia, and 9 metastases. And 7 of the 9 were from splenic hemangiosarc, one splenic melanoma, and 1 intestinal sarcoma. So, like the summary is not a very like easy reading paper, because when you read the result and you read the discussion, there seems to be some contradiction. So I try to get the the best of it, and it's kind of quite simple. It's like the hepatocellular carcinoma, they were mainly heterogeneous. We know why, and I will repeat it like several times, like mainly because like when they're aggressive, a tumor with a necrosis and hemorrhage, so they're much more heterogeneous, and so they show this very various hyper, hyzo, hypo enhancement in arterial and portal phases, but they have a tendency, we'll see it later, to be more hypo attenuating in a delayed phase. Regarding the nodular hyperplasia, they were usually homogeneous, mainly because there is it's very rare that there is a necrosis of hemorrhage, and they were hyper-enhancing in arterial and portal phases, and more like hyzo-attenuating in delayed phase compared to the surrounding parenchyma. Looking at the metastatic lesion, they were hypoenhancing in all phase and quite homogeneous. And overall, the Hansfield unit of the metastatic lesion were much lower than hepatocellular carcinoma and nodular hyperplasia in all phases. And the nodular hyperplasia had quite high like attenuation values as well in portal and delayed phase. So this is like the main part of the discussion was that you cannot just look, of course, at the Hansfield unit, and you need to compare to the surrounding parenchyma and also like the behavior in dynamic way. So it's really like to show that the triple phase CT is very important, the dynamic like evaluation. In human, is like they just based their their criteria just on these vascular dynamic findings. And the typical enhancement for hepatocellular carcinoma in humans is an early arterial uptake followed by a washout in the portal venous or late delayed phase. And in humans, the enhancement pattern is affected by the mass size and cellular differentiation. All this kind of relationship with the mass wasn't found in this paper. In another one, it was found that there was some kind of correlation. And so they suggest that the vascular dynamics of hepatocellular carcinoma in dogs differ a little bit of humans, but they're not really accessing it. They are not like investigating the cellular differentiation and the angiogenesis in these dogs. So I think we are kind of, we just look at images, we just do the histopath and we see, okay, so I think we are kind of maybe limited in our interpretation of the images because we don't go further as human medicine has done. So of course, large scale studies are needed to determine the sensitivity and specificity of this triple phase CT to predict the classification of hepatic mass between malignant and benign. Just yes, an example of the hepatocellular carcinoma, plain arterial portal and delayed, and you can see, of course, the heterogeneous enhancement that is kind of persisting on the different during different phases. Nodular hyperplasia, smaller lesion, they describe it like more homogeneous, and you can see like in delayed phase, it was iso attenuating relatively to the surrounding parenchyma. This one was again nodular hyperplasia, a little bit bigger with some more homogeneous. Yes, compared to the hepatocellular carcinoma, much more homogeneous, and also like this really like iso attenuation in delayed phase. And this was a case of metastatic tumor that was much like tiny and could see like hypoenhancement in all three phases. The second paper was a lot of numbers, but maybe more kind of useful if we, but it start to ask us quite a lot of time in the interpretation of the study, but why not? So the aim was to determine the clinical relevance for a quantitative and qualitative feature of canine hepatic masses evaluated by triphasic CT and B-mode color flow power and pulse wave Doppler ultrasound. And also the second aim was to compare the diagnostic accuracy of these modalities to predicting the mass type on the basis of the histopath classification. So there were a smaller number of dogs, 44 dogs, and they all had a mass that were bigger than 2 centimeters in a way that biopsy sampling was possible. 30 masses were malignant with a predominance of hepatocellular carcinoma, but there was also metastatic hemangiosarc, cholangiocarcinoma, biliary carcinoma, spindle cell sarcoma, and 16 benign masses, much more like various than the previous study with nodular hyperplasia, steroid hepatopathy, hepatitis, vacuolar hepatopathy, and biliary cystadenoma. And they use a little bit different CT protocol because they use the bolus tracking to start the aortic phase. And after the venous and delayed phases were acquired 20 seconds and 90 seconds after the start of the arterial scan. But grossly, it was kind of similar in time-wise, compared to the first paper that we look at. Just going through the evaluation, qualitative, quantitative in CT. So they look at the homogeneity, margination, if there was some mineralization and remanencement, looking at the vascularization, the distribution, if there was some tortuosity, and of course the attenuation values. And it was, attenuation values was a big thing in this paper, you will see. and the size of the mass. In ultrasound, same homogeneity, cogenicity, margination. There was some cavitation, vascularity is the same. And also when they measure the resistive and pulsatility index and the size of the mass. Sorry. So here you can see there is a huge table with many attenuation values. So they measured and calculated. So they look, of course, at the attenuation of the normal liver in plain post-contrast images, and also looking at the masses, they look at the low attenuation value and at the highest attenuation value. And they also calculated absolute attenuation values and relative attenuation values. So, and also the mass conspicuity, which was the attenuation of the mass minus the attenuation of the liver, and all this for the different phases. So they ended with, as you can see, many values for each of the each single masses. And what came out is like, so they did different statistical analysis, and they elaborated an equation that included, so one of these attenuation values, so the lowest delayed phase absolute enhancement of the mass and the highest venous phase mass conspicuity. And this was used to correctly classify like nearly 94% of the masses as benign or malignant. And they found as well, and they elaborate as well, another equation with just a single variable that was the lowest absolute delayed enhancement of the mass. And that was used to correctly classify 91% of the masses, with the expectation that the malignancy, that there was, the mass was malignant if the value that was the result of the equation was lower than 37 Hounsfield units. For the first for the first equation with the two variables, it was the equation with the highest score that could predict the type of the mass. So, I mean, like this, maybe you say, oh, what it is, but if you take time when you're reading, it makes sense, and we can understand it. Ultrasonography was much more simpler. It was like if there was cavitation, was in with accuracy of 80% that it was a malignant mass. So this is just like this equation with two variables. It's just a reminder, but I won't go through it because you won't remember this. But just like remember that this equation, I think, have a quite good accuracy, and if you see sensitivity to predict malignancy was as well quite reasonable, I think. So looking at some images, how they put the ROI, this was a case of hepatocellular carcinoma, and so you can see this variable of lowest attenuating region of the mass depicted by the white circle, and the highest attenuating region of the mass. So, and you can see as well that there was, so it is just to show how they put the different ROI in different phases. This was a benign nodular hyperplastic mass, and you can see that the mass in the pre-contrast image is relatively homogeneous appearance, and there was a moderate enhancement of all the areas of the mass in the delayed phase, quite isoattenuating as well. So, so after they discuss a bit like, okay, so we have this equation, they have good sensitivity, specificity, good accuracy, and they try to understand why we have this kind of results. So the measurement of less than 37 Hounsfield units was which is completely logical, seen in region with lack of or extremely limited uptake. And the theory behind this is like they are region of necrosis. And so this is like a necrotic lesion are frequently seen in hepatocellular carcinoma and much less in benign lesion. So the presence of the necrosis is strongly related to the aggressive characteristic and can be of course the result of the tumor-related hypoxia as the tumors outgrow their blood supply, so they become necrotic. Same for the cavitation that we can see on ultrasound that were related to tumor necrosis. All the pulsatility resistive index, all the rest that was not useful to discriminate malignant versus a benign lesion, at least in this study. However, so just they went back and it was interesting, but like the 4 masses that were misclassified by all observers, and most likely the result of the inherent characteristic of the masses. The retrospect, there were like 2 hepatocellular carcinoma that were classified as benign. And finally, the retrospective review shows that there was a limited heterogeneity, most likely due to the small kind of size of the lesion. And it was possible that the non-enhancing areas of necrosis or the necrosis were not yet present. So it was more like depending of the stage. And I think this is quite interesting and of course can lead to a lot of cases of misclassification. The biliary cystadenoma, which is a benign lesion, was misclassified as malignant because like this type of mass have a huge cystic component. So of course they would yield to very low attenuation value. So in this study to false positive. After there was a misclassification for the corticosteroid hepatopathy, but they didn't really know how to explain it. Yes, this was the case of the biliary cystadenoma. I mean, definitely, yes. It looks a little bit, it's less heterogeneous than a hepatocellular carcinoma, but you have this large area of fluid accumulation. So there was the main limitation of this study was there was only 44 dogs and also the small biopsy sample that could lead to some misdiagnosis, not misdiagnosis, but they say, yeah, I mean, they don't really explain why, but it was mainly like they insisted more on the small sample of the population that they studied. And so this measurement of these CT variables in multiple phase CT and the use of this equation can increase the accuracy of the classification for benign and malignant hepatic masses. So if you're ready to do all this ROI and equation and measurement, maybe it can be interesting to see how if it's really accurate, but why not? And this one is like really quick review. It was oldest paper, 2012. One of the first paper that look at the CT characteristic of the primary hepatic mass. So I think most of us we should have go through this paper for the exam. Just the protocol was a little bit more like the first paper with set times of acquisition. The common findings for hepatocellular carcinoma with a central marginal enhancement in the arterial phase in the majority cis-like lesions, as we saw, capsule formation and hypoattenuation in the portal and delayed phases. I think it also depends of the size of the mass. Hepatic adenoma was characterized by diffuse enhancements during the arterial phase, but this was also found in nodular hyperplasia. And usually the contrast retention in portal and delayed phase was characteristic for benign hepatic lesion, and even more in adenoma compared to nodular hyperplasia. And as we saw in the previous paper, that in case of nodular hyperplasia, they were frequently isoattenuating in the delayed phase. So I think this is something that is really redundant. I found a little bit more kind of consistency in this through this paper than maybe for splenic masses. So maybe I think it can be is a little bit easier, maybe to feel sure on discriminating malignant and benign for the liver compared to the spleen. And the nodular hyperplasia was less likely to have a capsule, and the mass size was significantly smaller in nodular hyperplasia than hepatocellular carcinoma and hepatic adenoma. But I think considering the small size of the population, I'm not sure we can really take this conclusion for granted. Just a case, yes, of hepatocellular with the, you can see the in the arterial phase enhanced arteries in the center of the lesion, and also like kind of they mentioned that this was a tumor capsule. Yes, I think yes, I can really see the capsule. And also like in delayed phases, the lesion was mainly hypoattenuating compared to the surrounding liver. Yes, mainly due to the cavitation. I don't think it was a more obvious example. And here, hepatic adenoma with a retention of the hyperattenuation in the portal phases with the surrounding liver. So one of the characteristics of adenoma, and quite isoattenuating in the delayed phase that they call equilibrium phase. This was nodular hyperplasia, and we can see isoattenuating in delayed phase, and otherwise quite hyperattenuating, a little bit heterogeneous in arterial phase, but much more homogeneous in the portal phase. Yeah, and this was just like 3 papers about the localization. So the first one is just one slides for each paper. So the first one was to determine the anatomical origin of the canine hepatic mass using a CT. So it was done, yes, in 57 hepatic masses. So they look at different criteria, and I think what we could kind of retain is like these following guidelines that suggested that a hepatic mass entirely located to the left of the midline will be left divisional. A hepatic mass medial, lateral, or dorsal to the portal vein will be right divisional. When you have dorsal displacement of the stomach, it's usually caused by a left divisional mass. And when you have left displacement of the stomach, is usually caused by a right divisional mass. And the hepatic lobar veins or the portal branches can be used to distinguish right central and left divisional masses in the ventral abdomen. And I think is me personally is what I use the most, is looking at the hepatic and portal branches to help me to identify which lobe is affected. Another one, yes, quite recent, but just that looking at the accuracy of CT and ultrasonography to localize solitary hepatic masses. I'm sorry, I still find it strange to do this kind of paper in 2019, considering all the things that we can do, but I think it is good. So the location by ultrasound was correct in 70% of the cases, and CT was more sensitive with 80% of the masses that were correctly localized. And the last paper is a paper that I presented, I don't remember if it was a few months ago or last year. It was last year anyway, and it was just the use of positive contrast CT peritoneography that improved the delineation of the hepatic interlobar fissure in cadavers, and that could, so that could, like, you can differentiate much more like the so the different lobes. Yeah, so it was one paper that I presented, so I think nothing really new, but it was a potential technique to use if other criteria cannot be used to localize the mass. And I think, yeah, that's all. So we'll stop the sharing. Do you have any question? I've been fast, I'm sorry.
No questions from me. Just a comment here on the paper from my mast cell tumor. They talk about liver as well, but I think they also mentioned that it's, yeah, for the liver, it was not that useful. And well,
yeah, I'm sorry, I didn't present it like this one because I wasn't.
no, but yeah,
sure.
so I just wanted to add, yeah, I think it was also not that specific, or even that they couldn't see lesions, I think, in the liver for the lymphoma, if I remember well. Or was it a mast cell tumor? I don't remember, but one of them. But yeah, so it was also not very conclusive for liver as well as for spleen. I just mentioned it because I read the abstract quickly about the liver when I was preparing for the spleen. So.
I think maybe it's a little bit more like listening to you and look that it might be, yeah, CT might be more kind of discriminative for liver mass compared to splenic, but we end always with the same list of differentials. But maybe if we were doing more things like human, looking more at cellular differentiation, and because it's very simple, I don't know. I've never done any study of this type, so I cannot see like the limitation.
Yeah, well, one thing for sure is that I won't start tracing Roy and then make equations.
No, but I think it was surprisingly the good accuracy. So maybe.
Yeah. Well. Yeah. Okay.
Important, like if you have many, maybe if I've got time, I could. I mean, this paper was hard at the beginning to understand, but after it's kind of straightforward, just okay. Yeah, subtraction. So we can still do it.
Good.
Anyone has any question?
Nothing in the chat, no.
There was a lot of hyper, hypo, iso, but
yeah, well, yeah.
You will have the. I mean, with the theme we have to go through quite a large number of papers, so sometimes it is a little bit redundant.
Good. Well, if nobody has questions,
can I just make one comment?
Yeah, sure.
Yes, please.
You know, we have all these studies, and yet it doesn't. When people do CTs, it doesn't really address the questions that need to be answered, which is how feasible is it to remove it? How feasible? You know, it doesn't tell us whether there are adhesions present. You know, and as radiologists. Even though some of those papers have surgeons on the paper, they don't really address the fact that, you know, for many left liver lobe masses, you have to remove the entire left lobe because the portal, regardless of what the portal vein supply is, you need to remove the effective venous supply to those lobes. So, you know, whenever I see hepatic masses, probably what they are is of less relevance compared to what are you going to do about it?
Yeah, no, yeah, I agree. It's true. I guess, yeah, for the spleen is not really a question, but for the liver, definitely questions we got on the reports from the clients is it removable, which lobe is affected, all those kind of things. Yeah.
Yeah. I mean, what I often tend to try and say is that, you know, if something's got a clear peduncle, if it's peripheral, and perhaps suggest whether something is, you know, complicated because of the venous drainage or the, you know, and there's no point getting too involved about whether it's malignant or benign if you go and miss hepatic metastases, for example. So some of this is a little bit distracting to some extent.
No, I agree. I agree with you. It's definitely from our point of view, and that's what I often say to other radiologists. I say, well, yeah, it's not histology anyway, so we will never be sure what it is. And definitely, you're right. When we have a mass, it's more important to describe margins, adhesions if we can. location, vascularization, etc., rather than speculating too much about what it is.
Because I think because in humans it's completely different, because they will treat every single they will have to identify every single lesion, for example, in the liver, to see if they do chemo radiotherapy. So it will be really something that they do follow-ups, and so we are completely in different. Us, we remove the lobe, and and that's it. So it's true that it's completely different way. So maybe sometime we try to, as you say, and like to apply things, like research or theme of paper from humans, but in the real life, I mean, we will never treat as a like we treat a human a patient. So.
And hepatocellular carcinomas in humans have a high association with hepatitis.
Yes.
Hepatitis C virus, and so the comparison is much more difficult. And these have been dogs, but obviously in cats, I think the situation is even more complicated because, at least in my experience, parenchymal, many of the tumors are more ductile related than adenocarcinomas, or adenocarcinomas tend to be cholangiocellular. So thank you very much.
Thank you, Andrew.
It's true that we treated mostly dogs. I didn't find that many articles about cats, I must say. There was not that, but I guess they are less prone to liver and splenic masses than dogs. Surgical planning or criteria to look at for that, to be honest, apart from the localization of the mass, which I included quickly and thought it was nice to have in the literature there, to have the different things about localization, but otherwise, about surgical aspects and stuff like that. It's true that none of those articles really touch base with that.
Sorry, one last thing just to comment on. It's interesting. You only looked at CT primarily for these, did you? For the hepatic mass.
It was.
Yeah, the paper selected were, yes.
Yeah. Okay.
Yeah, I was biased on CT. Obviously, we rarely cover ultrasound. Because we don't do it here. But although I appreciate a lot of you are still doing ultrasound. But actually there were a few articles about MRI, but I didn't include those, to be honest.
No, that's a resident project, not real life. Thank you.
Good. Well, if there's no more questions, then have a good evening, night, everybody.
Yes. Thank you very much.
And see you next time.
Thank you. Bye-bye.
Bye.
Thank you. Bye-bye.